Yeah.
And welcome back, everyone, to another episode of Living with FASD, a human interest and educational show for people living with fetal alcohol spectrum disorders by someone with both professional and personal living experience with FASD. And so this week, we are going to be spending our time with oh my God, with Dr. Paul Connor, who is a clinical neuropsychologist up in Washington. He's worked for a number of years as a researcher, studying the impacts of prenatal exposure of alcohol on adults. And he has been in private practice now for 16 years, primarily working in private practice excuse me, assessing adults for FASD. However, he also does some forensic work, which is fascinating. And hopefully he can tell us all about those things. So welcome, Dr. Connor, to Living with FASD.
Thanks
So
for
glad to
inviting
have
me.
you. Yeah. So let me start with what got you interested in FASD?
It was really an accidental tale. I had been off on my internship as part of my Ph.D. program. You have to do a year of internship.
Mm-hmm.
And I was on my internship in Detroit, Michigan, and I wanted to come back home to Seattle, Washington. So I was looking at programs there, the clinical program at the University of Washington. And the head of that program said, "Oh, you should probably talk to one of my friends who she really needs a good neuropsychologist to help out with the research project that she's on." And that person that she recommended was Dr. Ann Streiskuth.
Oh, yes.
And so I had not known anything really about FASD at the time. This was back in 1995.
Okay.
And so I was looking through all of my old textbooks about in neuropsychology to see what it said about FASD, and I found one paragraph about it.
Wait,
And it
that's
happened.
more than I got in grad school, because I got my master's in 1990, and guess what I learned about FASD?
Yes,
Zilch,
yeah,
nothing, not a peep.
yeah, and it was kind of eye-opening that there was so little and so
Yeah.
much where neuropsychology kind of has a big play in FASD. That one paragraph did reference Dr. Ann Streiskuth, so I knew I was kind of going to a place where somebody knew about the process, about the condition. So
Yeah.
that's what got me into it.
Okay. And you've stayed this whole time. So
you kind of get roped in and you stay in the area because one, it's very fascinating. I really enjoy working with the people.
mm-hmm.
And two, once you get known for something, it's hard to get away if you had wanted to.
Yeah. Well, I think because there's such variety in the way people with FASD present,
Mm-hmm.
It adds a lot of variety just to the basic work,
Mm-hmm.
right? Because the cases are also different. People's lives are also different. And how many assessments have you complete? Like, what percentage of people that you assess end up being on the spectrum?
Well, I mean, it's a good question. It's not one that I have specific numbers for.
Rough ballpark.
Rough ballpark. I mean, the FASD assessments are a portion of my clinical practice. It's not my entirety of the practice. And when I do see somebody who was suspected of prenatal alcohol exposure, probably about, I don't know, maybe 70–75% of the time they do end up having a formal diagnosis. There are certainly a number of cases that I've worked with where they have some challenges, but they don't have impairments that are sufficiently severe or impacting them on a day-to-day basis that would warrant a clinical diagnosis. So we talk about how we can work around that and recognizing that yes, this may have an impact on you, but it's maybe not as severe as it needs to be for the title to be applied to it.
Yeah. I think from the people that I have talked to, that's a little frustrating
Oh, absolutely.
To not get that, because the impairments that they do very much feel, it seems to them they get minimized, right?
It really does, you know, and it is unfortunate. You know, I I I tend to use a diagnostic system that is very structured, so I can apply it to everybody equally, basically.
Yeah. Right.
And so that means that some people just kind of fall right underneath that threshold. And in those cases, it's definitely like, no, I believe you. There are challenges, and it probably has had an impact on you. And we can talk about, you know, as if you did have a diagnosis, these are things that you might go about. So even when a person doesn't get diagnosed, I often have a lot of recommendations about things that they can do. And oftentimes those recommendations are very similar to the individuals who were diagnosed.
Yeah.
So.
Yeah. I know, in talking with Dr. Kathy Page, several weeks ago, when we were leading up to the idea of doing the podcast, she was saying that she tells people to conduct their lives as if they had the diagnosis, simply because the overwhelming number of people that would want to be assessed compared to available diagnosticians such as yourself, it's overwhelming.
It really is. I mean, there are very few people who, you know, there are definitely programs for children around the country that do assessments and diagnosis. There are a number of them, but even they are over capacity. They don't have the capacity for it. You know, but when we get to an adult condition, it's not something that a lot of neuropsychologists pay much attention to. A lot of neuropsychologists tend to be more acquired conditions, head injuries or strokes or things like that may have occurred later in life, and there was a change of functioning. But FASD is a developmental condition, and so you would think of it as a child neuropsychologist would handle that, but it's a lifelong neurodevelopmental condition. So they move into adulthood, and there just aren't many practitioners that are focused on it.
So you were involved in research for how many years before you left for private practice?
I started in 1995 and left the university in my for payroll in 2008.
Okay, so 13 years,
about
roughly.
that.
Yeah. What kinds of things? I mean, you were looking at the impact of prenatal exposure in adults. What kinds of things did you uncover in your work, or were there any surprises?
Well, we did a lot of work because we had a couple of different cohorts or groups of people that we were following. There was a group of people that we were following who they were interviewed. Moms were interviewed while they were pregnant, and reporting various quantities of alcohol use or lack of alcohol use, abstinence during pregnancy. And then a group of those children were followed, and it was originally going to be for 18 months or something. And by the time I came onto the study, they were 21, and we were following them up into their 30s. And then we had a second cohort of people who had been clinically diagnosed with an FASD, or back in the day, fetal alcohol syndrome or fetal alcohol effect. And so we were doing evaluations with them. So the nice thing was that we could do some of the same sorts of research with our prospective cohort, our group of growing kids with various levels of alcohol exposure, and with the diagnosed cohort group. And so we were doing neuroimaging work and finding, like a number of other groups around the country, changes in the corpus callosum, which is the white matter pathway that connects between the two halves of the brain, changes in the cerebellum, which is in the back of your head, which is, at least traditionally, we always thought it was just motor coordination and stuff like that, but we understand now that there's a lot more cognitive impact from it, especially with timing and interactions of behaviors and things like that.
Okay.
So we were finding a lot of those sorts of things, which weren't necessarily surprising because they'd seen some of these issues in animal literature, and we were confirming in human studies as well. We were also doing neuropsychological testing, looking at memory and executive functioning problem situations, and we were finding that people were doing much worse than might be expected based off of their IQ on kind of these more executive functioning or complex planning and problem solving skills. We were also doing research on mental health functioning and finding that almost over 90% of individuals with FASD had some mental health problems that they needed assistance for. And one of the studies that was going on at the time that I was there was finding that almost 40% of people with FASD had been diagnosed with some sort of a psychotic condition at some point in their lives. So that was kind of a surprising thing for us. We'd known for a long time, and kind of the research was showing that oftentimes the first diagnosis that kids who eventually get an FASD diagnosis receive is ADHD, because the attention and impulsivity is a fairly core piece a lot of times for people with FASD.
Right. Okay. So with the mental health issues, I mean, obviously when someone is chronically misunderstood or chronically assigned blame for their poor choices, right? Which aren't, I mean, I'm not going to go down that rabbit hole, but it's no wonder that there are higher rates for anxiety and depression.
For sure. And those are what we often call kind of secondary disabilities, because it's not necessarily what they're born with, but it's kind of the baggage that comes along because of the condition. But also, if you think about mental health from a neurological perspective, it's also likely fairly primary as well, because alcohol affects the development of the brain. And the brain is very much involved in mental health because it's the neurotransmitters. And so if it's affecting the neurotransmitter system, the person is already predisposed to a lot of these mental health problems. So they may have them primarily because of the actual damage to their brain, and then secondarily because of the stigma and the challenges that they face in life.
So, and that's kind of where I was going with this was, have you found in all those years of research, and then since in your private practice, that issues with anxiety and depression, do they tend to be episodic, like reactions to life, or do they tend to be chronic?
It can be both. It can be both. And when I'm interviewing some people who eventually I do end up diagnosing with FASD, sometimes they're talking about mental health troubles beginning at a very, very early age, and suicidality beginning at a very, very early age, and even substance use that begins at a very early age, or substance use problems that begin at an early age. And that's kind of telling me a little bit more that this is kind of on the neurological side. There's something wired there that's creating the challenges that then get exacerbated or added on to.
Could that be in the cases with the substance use disorder that you have seen? Do you think that might be, and it's probably hard to answer, how much of that do you think might be secondary to the FASD itself versus the epigenetic effects from dad's use?
Yeah, dad's use is a very good question, and we just don't know yet. And the challenge with the impact of understanding the impact of dad's use is, one, it won't be an FASD. It's a different condition because it's a genetic condition, because the only way that dad passes on medically is the genetics in the sperm, and sperm gets regenerated fairly often, so it does require alcohol use very close to that time, et cetera, et cetera. So it's it's a complicated question. So the substance use issues that we've seen when they've done animal research, they've definitely found that animals that are exposed to prenatal alcohol are preferentially choosing alcohol in their life. So we know that it can have that impact. And in some of the research that had been done in our unit that predated me, they were finding that even as early teenagers, these kids that had been exposed were getting into troubles for use of substances. It wasn't just experimental; it was getting into troubles for it. So, it does seem to be something that's linked in with the actual condition itself, FASD, prenatal exposure.
And any idea on percentages of how many of us struggle with substance use?
I don't know that specifically.
That probably changes from time to time.
And it may change from time to time. And also, what I've noticed is that there's kind of this, there are kind of two groups of people with FASD with respect to substance use. And there's the one group that, they do have a lot of troubles with it, and they kind of fall into it, and it's hard, and they get caught up in it. And then there's the other group who are, my mom used alcohol while she was pregnant with me. It caused this problem. I am never touching the stuff. So they get very much on the opposite side, and they're very strong advocates for abstinence. So because of that, doing just an average, you kind of lose that information about those two types of responses.
And I'm also curious if it's more the alcohol itself, the chemical formation that the brain goes, oh, I haven't had this in a long time, glam onto it, right? Or if it's just the addictive process, right? Because behaviors can be equally addicting as substances can.
Yeah, it's a good question. I'm not sure.
Yeah, I come up with good questions once in a while. Too many years of college.
There you go.
Professional student over here. Okay. Were there any surprises as throughout your time in research? What was the most surprising thing for you to have learned as you really took a deep dive into the world of FASD?
I think a lot of I didn't notice many surprises, to be honest with you. Because one of the things that our unit that Dr. Streiskuth set up was that they always wanted to be connected with the people with FASD. And so a lot of times they would bring us ideas, and they'd say, these are the things that we're having problems with. What can you do about figuring out, is that maybe because of the FASD? So it was, we kind of knew that these were possibilities. So it was oftentimes not a surprise when we found that, yes, this was an issue that seems to be connected or seems to be related in some way. And always with the research, it's, we don't know what our outcomes will be, but it's always very interesting to follow down that rabbit hole of the research.
So you must have really been intrigued. Have you read the survey that the FASD Changemakers put out on the 428 comorbid conditions?
Yeah,
that must have been intriguing.
It is. It was something that we had talked about, our concerns that there might have been a lot more medical issues and a lot, maybe, early dementias and things like that in people with FASD. We just never were able to do the research on that. So it was terrific when, the Changemakers got together and were doing their surveys and kind of looking at all these comorbid conditions. It was terrific.
Yeah. I found myself really wishing that it had really finessed that early diagnosis of dementia, because there's so many of them. There's so many, and most people don't realize how many dementias there are. But from a personal level, because of my type 1 diabetes, I'm already predisposed from that to both Alzheimer's and vascular. But I'm also a full-time caregiver for my mom who's got Lewy body. No one else in the family has lived long enough to get dementia.
Okay.
Cancer takes most of them out
Oh,
way
shoot.
before my mom. She just turned 91 the other day.
Oh, well,
Bless
congratulations.
her heart. Yeah.
Yeah.
But when I listened to that episode on FASD family life, I was like, so I listened to it like 5 times. And I was getting a new neurologist for my mom because this is going to sound horrid. She wasn't dying fast enough, so she got thrown off hospice.
Oh, yeah.
So that I'm going to change neurologists while I'm at it. And I went ahead and made an appointment for myself as well, because I wanted a baseline. Right.
Yeah.
And they did an MRI and a PET scan and then a mini mental status exam, which was really disappointing that was sufficient. Right. And even it was disappointing for my mom that that's all they did. Because with Lewy body, they do something called show timing, which is a variation of masking, except that they can pull all their cognitive resources and actually function normally for a short amount of time. Yeah. And then, of course, they sleep for days. So
yeah, I remember in grad school, we would joke about pretty much everybody should get a neuropsych evaluation when they're like 25. So it's just in the bank, so that if when something ever happens, you've got this thing to compare to.
Yes.
Totally impractical, but it would be a good idea.
But it was interesting though, because the neurologist was like, well, you're at like an 88% of functional score, and that's a B+ in life. You're doing great. And I'm thinking, B+. He doesn't know how far of a fall that is for me.
Right.
Of course, I thought of that snappy comeback in the parking lot.
Of course.
So what, I had those fancy scans. What is that done in the assessment process for FASD? I mean, do you guys, I know you were doing that in the research, but is it part of a normal assessment that people could expect to go through if they come to you or someone else?
Well, it depends on the placement, on the where they go. Some programs do use neuroimaging pretty commonly. I'm just a solo practitioner, so they come to me, they get neuropsychological testing. I might recommend neuroimaging. And certainly when I'm involved in forensic cases, neuroimaging is very commonly done. The challenge that we run into with neuroimaging is that if they just do these scans, the MRIs, and then have a clinical neuroradiologist just take a look at it and do their normal clinical read, oftentimes they're not picking up on the subtleties that we see in the changes for people's brains that do have FASDs. They're looking, and they have to go through a lot of images in a fairly short amount of time. So they're looking for obvious things like tumors or midline shifts where kind of the brain is kind of shifted over to one side or the other side. Or
what
bleeds.
causes that?
That can be a tumor, it could be bleeds, could be a traumatic brain injury, could be swelling. Lots of things can cause that, but it's kind of one of those things that really is kind of a big red flag.
Something acquired.
Right. So yes, often acquired. Or looking at to see if the gray matter, the kind of the cell bodies of the brain are kind of shrunken and shriveled, that you do tend to see in kind of the dementia style cases, or cases where it's been a long time, they had a severe injury, and kind of the recovery period, they tend to kind of lose tissue.
Yeah. Well, and low blood sugar knocks that out too.
Yes, kind of over long time. So that's what the neuroradiologist is looking for. So a lot of times the clinical reads will be read as normal.
Mm-hmm.
And so what ends up usually needing to happen is to actually do very complicated, or not complicated, but very in-depth quantification of the brain structures. And so that is something that's not kind of always done as part of a normal clinical case.
Yeah.
It's certainly done for research, it's certainly done for forensic cases, but it's not necessarily something that happens a lot in a clinical case.
Yeah. Oh,
and
go ahead.
with my evaluation, the way that the diagnostic criteria are, certainly having a structural defect or issue on imaging will qualify as a central nervous system impairment, but the neuropsychological assessment can also, render that same information for that CNS component of the diagnosis.
So. Okay. So yeah, I know, and thinking about what I was told after my scans, there were some anomalies that the radiologist didn't know what they were, but he wasn't worried about it. So, and I asked the neurologist, could this be related to the prenatal alcohol exposure? And he didn't know what to tell me. So he said no.
Okay.
But he clearly was like, he thought for a moment, and yeah, it was kind of like, yeah, I don't think so. So I think it's probably just the lack of specialization.
Probably true. It's not necessarily something that is on every neurologist, radiologist, or general practitioner's mind, unfortunately. It's certainly something that can be, because it's a fairly, some research is indicating up to 5% of the population. So it's not a super uncommon.
That's 1 in
condition.
20 people.
Yeah. In various levels of impact, of course. But yeah, so it's unfortunate. There have been some medical school programs that do incorporate some FASD training into the medical school, and that's improving, and that's helpful. But even so, some of the research that's been done has indicated that medical doctors oftentimes are just uncomfortable making a diagnosis. Because they don't feel like they know enough about it. And
there's so often they will say, but we can definitely diagnose, ADHD or autism spectrum, thinking that at least it's a partial diagnosis, even if it's not complete. They have enough information to do that, and which will access services, but we know that it leaves off some things, and treatments for, autism, for example, might work very well for people who are truly on the spectrum, but not be helpful for people who have fetal alcohol spectrum disorder with autism spectrum disorder characteristics.
Yeah, well, there's a lot of overlap between autism spectrum and FASD, and not only just in the letters in their name, but so there is a lot of overlap, and so yes, there can be some benefits from some of the treatments that are applied for autism spectrum, but they usually do need to be modified in some way, because it just doesn't always fit. Similarly with ADHD treatments, some of the psychiatrists that I've worked with over the years, are finding that maybe some of these frontline medications like Ritalin don't seem to work as well for the people with FASD. Maybe one of these other ones tends to work better. They also talk about a lot of times that kind of the standard clinical dose of these medications sometimes is just too much for people with FASD. They get a lot of the side effects, but not a lot of the benefits. So they talk a lot about starting very low dose, working your way up slowly. So it's well-meaning, and it can be helpful to make the diagnoses of based on the symptoms, and not even if you can't get the etiological or the causal based diagnosis for FASD. And that's another thing that we run into relatively frequently. When I do my neuropsych evaluations, the neuropsych assessment for FASD is actually, I think, pretty straightforward, pretty simple. I wrote a chapter in a book that was published recently, and it kind of goes through, these are the tests that I give. And it was about a forensic setting, but can be applied clinically for sure.
Mhm.
And this is kind of the criteria that I use in making my determination whether somebody does have functioning that's consistent with an FASD or doesn't. The challenge for adult diagnosis of FASD isn't necessarily the testing, it's the history.
Yeah.
The exposure history, getting as much information about whether mom did use alcohol during pregnancy, as much as possible, kind of how much and how often, things like that. That can be a challenge, for sure. It's always a challenge throughout life. It can be a challenge. And then as they get into adulthood, also it's the rest of history, because the neuropsych testing is something that I do is very sensitive to prenatal alcohol exposure. It's not specific to it. So you can have a similar pattern of functioning for somebody that's had a significant head injury, brain injury, multifocal injury from, let's say, some sort of a large bad accident. So knowing the history is really important. So getting records, getting school records, showing that, yes, there were cognitive problems before Joey started, using drugs or had this head injury, to be able to give that timeline so that we can say that, yes, sure, it's quite possible that these things had an additive effect, but there's this underlying neurodevelopmental issue going on here. That's often the challenging part of an FASD assessment that I find.
And access to that confirmation, is very challenging. I self-identified, like 4 years ago. So my mom would have been 87. A lot of people don't live that long. And so that information would have been completely unavailable. And I would have been left with looking at my quirks compared to the list of primary and secondary characteristics, from my neurobehavioral training, but no confirmation, right? This is why you're seeing these things. And then I've also worked for a quarter century in child welfare. And so we know that the number of, where general population is 5%, it's up to 70% within foster care settings. And of all the kids who have been diagnosed, 80% are not raised by their parents. So, my heart really goes out to those families who cannot access the information because, the parents are, yes, we used, whatever drugs their child tested positive for at birth. But they're not going to say, oh yeah, and I also did alcohol, right? Because it's legal. And why take on that extra shame, right? So, it leaves a lot of these kids in a lurch in terms of not having the right kind of validation.
And it is something, like you say, I mean, I do see that in my cases, and a fair number of cases I see. I tell them that, I can't make the diagnosis because we don't know about the exposure. But I'll make a diagnosis that this is a neurodevelopmental disorder, unspecified, suspected, and then we talk about treating as if. If it's quacking like a duck, it's walking like a duck, it's eating like a duck, maybe it's a duck, but we just can't call it a duck. So a lot of those situations we're working on, yes, it's a neurodevelopmental disorder, yes, we think it is, but we just can't confirm it, so let's treat like as if it was.
I'm kind of chuckling at your analogy about the duck, because I often will explain to people why their child has the autism or the ADHD, but not the FASD. And in terms of saying, there's a phrase that if you hear hoofbeats, then look for the horses. They're around, right? Zebras make the same noise.
But they're a little bit less common around here.
So FASD is the zebra. So, okay. This has been a fascinating discussion. Was there any commonality amongst most of your cases that you've been able to observe?
The challenge with kind of looking for commonalities and universals is the nature of the exposure of alcohol exposure, because it can happen anytime during pregnancy. So and different systems are being kind of developed or worked on at different times during pregnancy. So you can get a lot of variability in presentation of the symptoms for FASD. Having said that, there are a few things that we see really commonly. Again, not universal, but really commonly. Certainly academic impairment, academic difficulties. Oftentimes they're involved in special education as kids. Math is usually the area that they have the greatest difficulties in. Usually when I'm doing my little interview and I say, oh, what was your hardest class? Almost every time they say that it's math. And then the
I
testing
found it
usually bears
depended
that
on
out
the
too.
teacher.
Absolutely. that is for sure.
Yeah.
Teachers do have a large impact on it, because kids with FASD, adults with FASD do a lot better with one-on-one, very focused, very structured, very assistance and those sorts of things. Another thing that we see really commonly are kind of visual spatial difficulties. I give tests that look at their visual spatial construction abilities, their ability to copy complicated images. And it's interesting because a lot of the people that I work with FASD, they're really, really good artists. They draw beautifully or things like that. But then when I have them copy this complicated figure, they have a lot of troubles with it.
Interesting.
So that's something that I do see pretty often. And then very frequently we'll see these planning and problem solving difficulties, but it's, again, not everybody. But kind of those two and then the attention challenges. Even if they weren't diagnosed, although most of them had been diagnosed or identified as having troubles with attention, we typically see that. The hyperactivity side of things is maybe less common as they become adults for the people with FASD, but we still see a lot of the impulsive side of things. So it's not necessarily bouncing off the walls, but it's doing things without thinking about it.
So do you think that's tied to the challenge in being able to predict outcomes?
It's a good question. And it's a difficult question to answer. When you post an event, ask somebody, did you know that could happen? They're going, oh yeah, it could have. And they can recognize that there are consequences to the behaviors. But at that moment, it's kind of, I see it, I want it, I got it. That not able to kind of step back as much. So the impulsivity comes through with that. And also a lot of times people with FASD are slow to process. And so even though they're impulsive, they're slow to process, that's a big potential problem because they're not giving themselves the time to figure it out.
Right.
So that's something that it's not necessarily they don't recognize cause and effect or consequences. It's that they just can't apply them at the time.
By the time they do, they've already done it.
Yeah.
Okay.
Yeah.
Well, I'm just so thrilled to have had you on the show, Dr. Connor. I really appreciate your time. I know you are extremely busy. And hopefully my book will be selling wildly and a lot of people will be calling you for services.
And that is fine. I'm happy to talk with people. We talked about capacity and is a problem, and it certainly is, but we're working on it. And, if there are neuropsychologists or psychologists out there who are at all interested, get hold of me. I'd be happy to train them and consult with them on cases because we need more providers to do that in order to kind of meet the needs that are out there.
Well, gosh, that has me wondering if I should make one last edit to my appendix, being a call to action for neurologists to get in touch with you. Uh,
You know, I'm game for that.
that,
You know,
yeah,
I was asked to do that in New Zealand. They asked me to come down and train some neuropsychologists. And
amazing.
so
That's
that was
wonderful.
terrific. And, I really enjoyed that. And now there's at least one neuropsychologist in New Zealand who's going gangbusters down there.
Okay.
So,
And you
I'm
got a
really
really
happy to
good
do that.
vacation out of the deal.
And it was a beautiful country, that's for sure.
Okay. Well, I actually have had a listener in New Zealand.
Hmm.
So,
Oh,
yeah.
that's terrific.
Yeah. So, but I don't want to take up too much of your time because we're coming up on that hour
Okay.
and I want to be respectful of your time. But I am so grateful to you for coming and spending this time with me and with the audience of Living with FASD. It has been a joy and a pleasure to sit at your feet and learn. So,
Thank you for inviting me. I really appreciate it.
yeah. All right. So, everyone, I can't believe another episode has come and gone already. Another one is wrapping up, and I'm just so thrilled that we could have this candid conversation today with Dr. Connor. If you need or want an assessment, then his contact information will be in the show notes, so you will be able to reach out to him. If you want to suggest any other FASD related topics or just want to reach out and say hi, then you can email me at livingwithfasdpodcast@gmail.com. Or even better, you can join the Facebook community, Living with FASD Podcast. So we'll be happy to see you over there. You can interact with other listeners, as well as, commenting on this episode or, whatever. It is your space. So join us next week for another candid conversation.